Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. Hey, welcome to Glenohumeral Gurus. Today it's my great pleasure to welcome my friend and colleague Pradnya Gadkari to today's session. Pradnya and I have had lots of discussions after these podcasts with Wieger Heijink, haven't we, Pradnya? So
Yes.
it's nice to we wanted to summarize some of the key theories of motor learning and motor control and really try and wrap that up and dig a bit further back into these theories. What do you think, Pradnya? Welcome.
Thanks for having me, Maggie. I think, yeah, it was a lot to take in from those podcasts and just got me thinking, oh, wow, this is something different that I haven't really thought about when working with patients. And so I think, yeah, we have lots to unpack in this podcast. And
Yeah, we definitely do. And when I reflect on what I learned from the session with Vika is really how biomechanical my treatment has been previously. And I have been all about load management and progressive strengthening and trying to build capacity in the shoulder musculature. And so then you argue, well, my patients are getting better. Why do I need to shift approach? What do you think?
I think, I agree with you in some respects, but then I also feel that then we have patients who we see are coming for they have seen other physios, been the problem there for years and years at that time, and then sometimes you refer them on for MRI. They have a second MRI, first MRI, but doesn't show significant change. So if you're looking from a structural point of perspective that we're loading the structures, tendons, what's different? Why are they still not getting better? So that's why I thought of Vika's approach that, hey, there is something else that we are missing in a
Yeah.
different way of seeing these patients.
Yeah, I would agree. And since my podcast with him, I've been playing around with some of the patients in clinic as you have, and I really see the benefits and maybe the blending is what we need
Yeah.
between a motor learning, motor control. How can we blend that, but still bring on load management, still bring on that building of capacity? How could you use these structures in together in some
And
way?
I think also identifying, the patients who
Mm,
would need at some point, you need a approach that how we've been doing, loading the capacity in the tissues, and when do we then change? Whether,
yeah.
yeah,
Who does it work for
who
and
does it
who
work for?
doesn't
Yeah.
it work for, I guess, and to try and identify those people early so that you're not continuing down a path of rehab that isn't successful for the patient. Hey,
Yeah.
so Pradnya, today I wanted to talk through some of these different theories of this because it's been really nice for me to dig right back into my early learning. It's been fun, hasn't it? Looking at firstly reflex theories, reactive stability, moving into motor program theory versus implicit learning, what we really know about that, and then moving into this dynamic systems constraint-led rehab and dig into who it works for, who it doesn't, what are the benefits of each approach. Does that sound okay? And then
Yeah.
we'll try and wrap that up. So if we dig back historically, I went right back to some of that work from Sherrington, where we start looking at some of those reflexes and then looking at how we use reflexes and what we know. And so we talked about the M1, M2, and M3 reflexes. You remember them from physio school? So M1, 20 to 50 milliseconds with no cortical involvement. It's the one that resists that sudden stretch. It's not predictive and it's not adaptable. And that's sort of what I took from there. M2, medium latency, 50 to 80 milliseconds. There is a bit of transcortical brainstem involvement. You could be modulated by task. And then M3, longer latency, 80 to 120 milliseconds. The pathway then involves some kind of cortical loop. This is fully task dependent and can be modulated. Is that what you understand? These three different layers of reflexes and how you think about
Yes.
that?
I mean, that's kind of the model from, I guess, from Sherrington, from what I understand. But
Hmm.
I think like how we move and what we do is far more complex than that, isn't it?
Yeah, and that's definitely the limitation of that
Limit.
model, isn't
Yeah.
it? Because I think initially it was, well, all your movement is based on reflexes, which we know now not to be true. But
Mm.
when I think about some of the work that I've been doing, moving your arm this way will bring on your anterior cuff because it responds to load. That and those stretches, your Golgi tendon organs, all that kind of stuff is really in response to those reflexes, isn't it?
Yeah.
Layering that up. Is that how you understand that?
I would say yes in some points, but again, like I guess if you've done it once and the second time, because then there is that knowledge, how long does it take for
Yeah,
the brain? Initially, like
yeah.
let's say the first might be, oh, this is something new, and there is a first initial reflex contraction. But I think with brain, it's such a fast and complex system that
Mm,
works.
mm,
Then the second time, if they are going to be pretty bit, we don't know, like whether has that planning already happened.
yes.
Yes.
But that only applies to those longer reflexes. That's
Reflexes.
what
Yeah.
was interesting for me to refresh when you think that spinal cord level, you can't modulate that with
No.
training.
Anything.
So yeah, I wonder how do you think, as I'm thinking through this, these multi-directional people with really capacious capsules, and then I've been loading them, and now what I think all this movement overhead, and I move there, I get them walking around with overhead balls or whatever to try and get their arm moving. I've been thinking about in response to load, but actually I'm probably feeding off some of this reflex pathways.
Some of it, yeah, initial thing with reflex as well. But again, because if they have to carry it, like you said, there's always an overlap because it's the
Mm,
whole planning of it, isn't
mm,
it? With
yeah,
And sometimes, I mean, I guess they are caring, but there might be a certain change and variation in that. So, with that variation, yes, you might get in maybe a reflex sort of contraction happening. And
yeah,
again, it changes to maintaining and carrying on. So, I think it might be, as I think Mika said in movement as well, when the simplest things is reaching when then you have perturbations. Yes, there are perturbations and you deviate from, but then you still reach the goal. So the goal is probably caring.
yeah, yes, yeah, and how that then works between each other. And then I started thinking around active stiffness, as you and I are both interested in having some stiffness around the joint for stability. And then the role of the muscle before they're perturbated. And depending on how much muscle contraction is, that would be your intrinsic active stiffness. Is that how you understand that fitting in together?
Yeah, I think you're right. With and I think and that's where I'm thinking that yes, some role of when we think about strengthening
Mm.
the muscle because we are trying to increase that active stiffness as well, isn't it?
Yeah, I
Yeah,
guess that you could argue that more hypertrophy, if we
okay.
come back to our capacity model, more hypertrophy will give you more stiffness,
Stiffness.
wouldn't it? So, yeah, it's fascinating. I've really enjoyed diving back into this. So I guess we can say that reflexes aren't just spinal twitches there, are they?
Yeah.
They're layered and gain modulated and really task dependent, embedded in how you move and how you work out that system.
Yeah, and I think with that task, I mean, the goal is something that to keep your hand steady or whatever that goal might be. And within that goal, if there are perturbations, that might be a switch initially that, oh, it's a reflex, and then overtaken by your, higher systems of control and planning that
Yeah.
that you don't deviate from the task then.
Yeah, you maintain the
Maintain it.
task, but with some unexpected activities, which is why the slosh pipes, the tidal tanks, the aqua bags. We were just talking before we came online about how realistic that is for patients, and I've been recommending they carry a bucket of water, which I'm not, because I wanted something to move and I wanted them to be able to practice that regularly. What are your thoughts in that space? Do you?
I think there might be like ideas of variation, milk bottles inverted. Sometimes I
Yes.
tell them to do that,
Yes.
that's a nice sort of perturbation
Yeah.
aspect
And
of
the
it.
sand as well, isn't there? There's devices where the sand moves. And again, I guess it's responding to that unexpected load. I wonder, traditionally, I have waited until later in the rehab to bring on some of that, what I would have called more advanced. But maybe that's not correct. Maybe if you were performing the task, then you are perturbated. I had thought about it as a quick response from the muscle and around driving from a tissue capacity, but actually it's your reflex.
Yeah, and I
So
think then the question is that then we should probably be doing those things maybe early on. But
yeah,
of course, like if someone's gone through surgery or, just in
yeah.
within those parameters of, I guess, how do we do it safely?
Yeah, to respect the
We
tissue
should.
too, isn't it? Yeah, it's really nice to dig into that. So the second theory that we've talked, and I've spent a lot of time in motor program theory and thinking around novice and expert learners and grading that up until they are able to perform tasks automatically without cognitive control. Like I really have dug into that, and it was really nice to go back to that idea of a generalized motor program. There are invariant features of a movement, relative timing, the sequency. The theory really is around you already have this plan in your brain, isn't it, that you then execute out through your system with regards to force and speed and amplitude and direction. Do you think what else do you think we need to know then around motor program theory? What's the
I think
understanding there?
from I think those programs, like we said, will novice, let's say novice learners, like if you're learning, it is all driven by the task and the environment.
Mm.
So
Mm.
depending on the task and your environment, and I think the constraints as we talk
Yeah.
about, like
Yes.
within the environment and within your own constraints, then we do the task and we repeat the task and and kind of with the repetition the learning happens. And
Mm.
from what I understand is, so it's about structuring the environment. If the environment is not conducive to learning, and
Yeah.
I think that's probably from a therapeutic point of view, is are we making the environment for learning? Because
Yeah.
there's lots of things around it that the feedback how you get, whether as we probably move on and see the implicit learning versus explicit
Yes.
learning.
Yes. And the timing of that feedback, eh?
Feedback
And whether
when
you allow people to process that yourself. And early when they're learning, you would give them, almost immediate
mistakes, yeah,
feedback. And later you would delay the feedback so they could have some cognitive appreciation on whether that was right or not. And then, the knowledge of results and the timing for that. I had
yeah,
really thought a lot about that process. And then to talk with Vika and because I guess from there, because there's lots of research around this, isn't there? Particularly, I guess, in healthy athletes. That's how that has been planned. Not so much in an injured population. Is I'm aware?
Yeah, I haven't seen much sort of in a
Mm.
musculoskeletal type of injured population.
Yeah, so we need to be careful about translating this. And I guess when I went back, I think of somebody with instability, say, I would say they move back to being a novice learner, that they move with hesitancy, they are in pain, so therefore they don't move freely. They move like a novice learner compared to an expert learner. But Vika would say different. He would
Yeah.
say they're an expert learner constrained by their fear or pain. And so the implicit approach that I had taken of feeling your subscapularis, have your subscapular, you're in the video,
I know.
you're implicit in this. That when we are like contracting subscapularis, really focus on, can you feel the muscle? Can you feel it back into range? That isn't something that's not his approach, is it?
No. And I think some of it I've been thinking about it, and I said like it really depends if you look at what lens if you look at it, right?
Yes,
So if
yes,
you think about your constraints, your dynamic system is influenced by the environmental constraints and the constraints within you, whether it is be the pain or,
mm,
maybe not having, I guess we're looking at muscle activation or control or whatever that is. But if we have the task which is shaped around it, and as we say that, because they have forgotten, I guess, to how to move, then they will try and use those constraints more efficiently, I suppose, to move.
yeah, yeah,
So yeah, I mean, I've been thinking with it that implicit sort of feeling of subscapularis and everything, that
yeah, me too.
where does
And
it lead
really,
to?
if you
Like
think,
ultimately, that if the task is to maintain it, how, like he would argue, why are we thinking about which muscles and what in rotator cuff? Because there is so much of, I guess, what did he say? Not the word co-contraction, but they
yes,
are switching on, switching off, switching on, switching off, depending on, I guess,
on
the
the
movement.
position.
If
And I
that's,
guess, yeah, my argument to that is if we have the range of movement through like, and here I am for people driving in their car at 90 degrees of abduction, moving into external and then internal rotation. If you have that amount of range and you don't have cuff control and activity through that range, that's when I think in an instability population you are at risk. And so I've been trying to make sure you have control in that range. And again, my approach has been quite specific, and that's something that I'm looking to expand now after once we learn through that. But so that you have that control all the way through,
mm,
maybe it doesn't particularly matter what muscles are doing what. What do you think?
what, and that's what sort of I'm beginning to think, that are we thinking about that sort of model of that subscap working in that range and through it? Maybe some people probably move or use a different sort of strategy, I suppose. We
Yeah.
haven't really
We still
explored
need to explore that,
it a
I
little bit
think,
more.
because at some degree, I think low level at subscapularis to hold on, it works for some people. And the same thing with you see moving into external rotation. If you don't have inner range posterior cuff, then you
Yeah,
move through your scapula. And so, yes, there are a billion ways to move,
move.
but you do that because you lack inner range strength. So
Yeah.
we need to think
Look and
think
think about
more.
like whether that's just what we think, or whether there are a number of different, I guess,
Yeah,
muscle strategies which people use.
yeah. I think if we go back to this motor program theory, I guess as I was reading through it, the theory struggles to explain things like rapid adaptability, if the changes are non-linear, emergent coordination. Like the actual theory is maybe a little bit simplistic, which is why I think that led us into dynamic systems and constraint-led rehab, isn't it? Is that
Yeah,
your understanding too, the limitations of the motor program theory?
yeah, I would say so. And again, like it depends, like how, I mean, this is all again sort of that motor learning literature. So,
Yes, isn't
you know,
it?
to how do we sort of look in, I guess, the people in front of us, which we are looking at, were driven by pain and
Mm.
other aspects of it,
Yeah, which I think leads into this dynamic
dynamic
systems
system.
really nicely. I mean, the theory proposes that movement is not centrally programmed and stored, but it emerges from an interaction between the individual, the task, and the environment. And that's what sets up the key constraints. So I just read you some of the notes I took.
Yeah,
The individual, the constraints that are there are the strength, the pain, the fear, the fatigue, the mobility, the proprioception. Task constraints are speed, accuracy, direction, the equipment that's available. And then the environmental constraints are like surface or weather or how the visual importance of the task and how you could manipulate each of those constraints to guide your patient's movement. It was really interesting for me to dig into it. It explains the non-linearity, it
mm,
explains the variability, or too rigid is unstable under perturbation, but too chaotic is really inefficient way of moving. So it does explain lots of those things, which is what Vika has taught us, in these podcasts. Do you have any
focus.
comments on this constraint-led approach?
Yeah, and I think that's where I'm thinking, like when you talk about like fear
Mm,
being a constraint.
yeah, I've been thinking about that too.
Mm. Or and I think when we look at from a different, like the neurological, like is perspective of the brain, we do know with fear it also changes
Yeah.
how that programming, I suppose,
Yeah.
happens, right, in our brain about.
Yeah, but is that like a motor program theory rather than this dynamic systems? Because we know that people who have had instability will light up in places of memory and places of emotion like fear. So we
Yeah,
know that that happens. So the argument could be, well, it affects your motor program. It
that's what I've been thinking, like in that sense, that then it makes sense that, with then you, I guess, move differently.
Yeah.
So probably some of
And
these,
you,
if you think of it as a constraint, even with pain, those chronic pain patients where you don't identify, like there's no structurally
yeah.
wrong, but then they're driven by so much, like pain is an experience and output like from the brain. So
Yeah.
if it's a constraint, but it does change those beliefs and attitudes and coping mechanisms is changing, probably even how you program, I guess,
Mm,
the movement is.
mm. And then some continuation on this dynamic systems is ecological dynamics. And I wasn't really across this before I had talked with Vika, but he would say that or the literature would say, if dynamic systems is about self movement and self-organizing, then ecological dynamics, the movement self-organizes in direct relation through the environment, through this perception action coupling. And that perception and movement are inseparable of each other. And you can kind of, what do you think about that? I guess as soon as you move, you have that perception that you're
And
moving.
then you, but my argument uh is it that simple? Or,
Yeah.
like
I think
I
we can
understand that you
agree.
move and you perceive and you get the perception of, whatever that movement for, I guess, the patients who are in pain say, that felt good, and you
Mm,
move again. But
mm,
is it's self-correcting from what the theory says?
yeah,
What does it mean in terms of rehab? That how often is it, once, twice, once they perceive and they move and then it's corrected, or do you do repetitions in variations? Like how do you structure it? What do you tell?
yeah. I guess surely it's the same. I mean, or not. I was thinking of somebody who's an expert pianist, they've practiced 10,000 hours. So yes, yeah, I And I guess how I had seen the work that I'd been doing with subscapularis, posterior cuff in isolation, evolving that through. Once you show people that it's there, they seem to then get it,
Yeah.
So I don't know, do you need to practice that? Because you can't account for all the variability. You can't account for all the situations that they're going to be exposed to.
So
So,
then leading on from there, then perhaps once they get a perception sort of action coupling of a certain movement, then you move
mhm.
on. And I guess you show them a different way of, I guess, varying the movement. Is that what you would
Yes.
think about rather than just having a task where they are moving in different ways? Because I guess they have become somewhat, I see that people limit it because you avoid
Yes.
that hurts. And, so once you have that happening that, oh, I can move and it feels good, let's change you to move in different ways, like different type
Yeah.
of task.
And maybe it depends how quickly people learn. My experience with patients hasn't been that. They need to practice it for a bit before they move into different. It will be interesting to get Vika's perspective on that. But and from the patients we've started playing. I mean, I shouldn't
I
say
guess so,
in the clinic,
but I suppose
offering
probably
alternative
one
approaches. Let's call it that.
that way. And I think from there, I've been asking people that what are, I guess, their meaningful movements, which are important, which they
Yeah.
always say that I'm not doing this because it hurts. What are you
Yeah.
avoiding?
Mm.
So maybe asking them those movements or tasks which they are avoiding because of a B pain, which generally
Pain
is,
or
yeah.
fear or
And let's see how
apprehension.
we can change that.
Yeah, by manipulating
Creating
each of those
constraints.
constraints. Yeah, it's going to be an interesting few months in the clinic while we work out who it works for and who it doesn't. Is that because that's the other thing? Vika would always start this way, and I would always start my way, but what I've seen is particularly in that multi-directional space, particularly where, and that's where I wanted to talk. It brings to mind a patient that I saw this last week who has really altered patterning in her scapula. She has posterior instability and she gets to around 100 degrees of flexion, and then she will dump in her scapula or depress her scapula side bend in her trunk, and for her, some of this kinetic chain, and I've been a bit dismissive of kinetic chain, but maybe it's not a strength factor from a capacity level. Maybe it's a movement organization. What do you think? Kinetic chain, how does that fit in here?
I agree, and I like the idea of because it's more of a not a strength issue, but a movement organization. Because I have a similar sort of patient, and he has issues with his scapula, basically, and we think maybe like in some part of it was a scapular driven thing, and it's a little bit of instability, and the movement feels like, oh, I'm stuck, I can't get it.
Yeah,
But again, shifting his weight to the opposite side,
yeah,
the movement organizes better. So it is like we argue from a sort of, I guess, again, biomechanical perspective that,
yeah,
there are certain muscle, like he's always laterally flexed on that side. So he's maybe like he uses his dorsal quite a bit.
yes,
But I
yes, and
think it
that's
is just
it's
he hasn't
more than
figured
that.
out the way of how I move better with, a different strategy. And once he
Yeah.
does that, it feels better. So,
Yeah. And that's why I've really liked that isometric loading to try to, and in that population, to try to show them a different way. And maybe I've been just trying to open up the little motor homunculus man. And I think sometimes in that population, when moving is so complex and you still using your strategy, if I show you, maybe I'm not increasing capacity of that one muscle. I think I'm isometrically loading, but I am increasing the cognitive awareness of a different muscle that could be incorporated into their pattern.
or group of
Yeah,
different. of
Because
different,
it never
yeah.
works by
Yeah,
itself.
because I guess some of those exercises, what we are doing, like having someone to hold in, we don't know. Like, yes, you need everything. Like you need your scapular muscles to maintain your arm steady.
Mm.
Sometimes some people might even use their core, so
Yes,
or holding a side plank, for example.
yes.
Yes, it's more than so. I guess we think of in terms of capacity, but it's actually much more.
Yeah,
Yeah.
there's all these things. Actually, a completely different theory explains what we were doing, and maybe that's why it's been working all along.
Yeah, and maintaining it steady. So
Yes.
is maybe some
It takes
muscles.
us back to your work, doesn't it? You know, that force appreciation and the learning
Yeah.
in that space.
So I think, and it is probably it's much more complex than maintaining steady. I think that surely some muscles, we can't say that all those rotator cuff, they might fatigue. There might be other muscles taking over the task momentarily,
Yeah.
maybe change, that sort of shifting
Yeah,
might be
which is
happening.
what we've seen, eh? Or I've
Yeah.
seen like when with that. So I did some EMG work, the isometric loading of your posterior cuff, and as you fatigue, it definitely tips out of your cuff and back into those scapular musculature, and your patterns then change under
Change.
fatigue. So it's really interesting space. Okay, Pradnya, so what does this mean? Let's wrap this up for people
Yeah.
driving to work. Now what? Now that we've dug into all these different theories, what's the take home for clinicians?
I think the take home message would be to look at the patient in, I guess, front of you. I wouldn't put, the whole approach that we're doing completely out, but I
Yeah,
think it's given me a bit more understanding of not being limited in terms of just
yes,
thinking of from a biomechanical muscle tissue tension loading or how can I'm still doing it, but how can I then layer it up or move beyond that? Because ultimately, our patients, their problem is their movement. They are not able to do their things what they want to do. How
yes.
can we sort of
How can we shift that?
shift
Yeah,
that?
and for me, it's really taken me back to, that clinical concepts article I wrote with Tim that I look back and think how biomechanically loaded it is and how if I was able to cleverly manipulate some of these theories into that instability framework, we could make that even better. So it's been really exciting, hasn't it? I've really
Article 2
enjoyed it.
incoming.
Yeah, yeah, yeah. It's been really fun. So thanks for your thoughts here. I appreciate
My
kicking around
pleasure.
ideas with you as always. It's been wonderful.
Thanks, Maggie.
See ya.
See ya.
And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.